My name is Pamela Lutsey from the University of Minnesota, sharing a little bit about day 2 of AHA Epi Lifestyle. Our day began with keynote lectures on the topic of COVID and cardiovascular disease. Dr. Scott Solomon from Harvard University shared about COVID and its links to cardiovascular risk, while Drs. Mercedes Carnethon brought in the intersection of health disparities and how it is impacting adverse COVID outcomes. Scott, do you want to talk about your presentation briefly?
I first of all wanted to thank the American Heart Association for the invitation to talk about this really important topic. We've known for a long time that infectious diseases could contribute to cardiovascular health. But we're seeing this so acutely in the setting of COVID-19, and there are links between COVID and the cardiovascular system that we're learning more and more about every day. We've seen that patients who have are at high risk for cardiovascular disease, people who have the risk factors that we are very familiar with, such as obesity, diabetes, hypertension, are at markedly increased risk for severe COVID-19. And that's led us to really begin to try to unravel some of the links between the cardiovascular system and the virus. I presented both the epidemiologic data suggesting that we had these links, but also some of the mechanistic data that link COVID to endothelial disease. We think that disorders of the endothelial system, which of course are more likely in patients with obesity, hypertension, diabetes, and other cardiovascular diseases and risk factors, these are contributing dramatically to the increased risk in patients with COVID-19. And part of this is because we know that the endothelial system is both activated in the disease, that there's increased both macro and microvascular thrombosis in the setting of COVID, and that there's even immunothrombosis, which is really the intersection between the increased inflammatory and immune response that we're seeing in patients with COVID and an increased risk of thromboembolic disease as well. We've also realized that our most vulnerable cardiovascular patients are at much higher risk in the setting of COVID-19. This is particularly true in the area that I study, which is heart failure, where patients who have heart failure come into the hospital with COVID. Their risk of dying of COVID is about 12-fold their risk of dying if they are admitted to the hospital with a heart failure hospitalization. And this means that we need to be particularly concerned about patients with pre-existing cardiovascular disease. We're also becoming more aware of the potential cardiovascular sequelae of COVID, and as we begin to study what has been called long COVID or post-acute sequelae of COVID, we're seeing more and more people presenting with persistent cardiovascular symptoms, and that's something we're going to have to study much more. And finally, I ended on what I thought was a hopeful note, in that we've made a tremendous amount of progress in terms of vaccines. It's really remarkable how fast we were able to do it and how effective these vaccines seem to be. And because this meeting in this community is all about prevention, preventing the disease is certainly the best way to prevent cardiovascular sequelae of COVID. And obviously we need to address some of the issues that are preventing people, not just in the United States, but all around the world, from getting vaccinated relatively quickly. So we certainly have learned a lot in the last 18 months about a disease that didn't exist before then. we're going to continue to learn and continue to study how this disease affects the cardiovascular system in our patients with cardiovascular disease.
Thank you, Scott, for that excellent summary. Mercedes, can you please now share a little bit about what you spoke on today?
Thank you so much for the opportunity to speak about this, and I'm very pleased that the American Heart Association took on this topic of COVID-19, which typically we would consider to be an infectious disease or a respiratory illness. And the reason that I'm so pleased that we did discuss it is that early on in the pandemic, when the first set of data started coming out of China and coming out of Italy, we saw patterns whereby those individuals who had pre-existing cardiovascular diseases had a higher rate of mortality. And at that time, we weren't able to adequately detect in the population who had asymptomatic disease, but we were looking really at the worst indicator, which is mortality. And when we saw those patterns, it was really the first hint that I had that when COVID-19 hit our shores in the United States, that we would see marked disparities in who was adversely affected by COVID-19. And unsurprisingly and disappointingly, the patterns of who experienced severe COVID-19 displayed the same disparities that we see in early onset cardiovascular diseases, in heart failure, in diabetes, in obesity, in chronic kidney disease, and end-stage renal disease. And unfortunately, the individuals who are most likely to be affected are those who are vulnerable. And I chose in this talk to really broadly define vulnerability, not just by race or ethnicity, which is what we most commonly use, but by other characteristics, by individuals who are in rural areas, by individuals with physical disabilities, mental disabilities, the socioeconomically distressed as well. And that's because each of those communities and populations lives in a context that places them at higher risk for the underlying risk factors that predispose to severe COVID-19. The emphasis in this past year on the effects of structural racism, on inequities, in uneven opportunities throughout the course of life really aligned to show us what we're seeing here in the COVID-19 pandemic. And so in my talk today, I was very pleased to be able to discuss the context in which these disparities have arisen, disparities that certainly do have the Black community, the Latinx, the Native community, those individuals with lower socioeconomic status bearing the greatest brunt from COVID-19, but then also to really extrapolate to think about what does this mean in our step forward. I was very pleased to learn a lot from Dr. Solomon's talk about who is affected and about where we stand now with vaccination. However, vaccination isn't going to be the end game in the reduction in disparities, and that's because we have disparities in who had access to vaccines early on. We have disparities in who's willing to take vaccines. And unfortunately, the populations who are vulnerable have more difficulty still receiving vaccines. And there's an understandable hesitancy or caution about wanting to take those vaccines. And so what we have to do really as a community, and I'm very pleased that this is at the forefront of the American Heart Association's priority list, is to really structure our healthcare delivery, structure our health messaging in a way that reaches out to those vulnerable communities so that we can provide resources and opportunities so that we can help to reduce these disparities and inequities. And so thank you very much for the opportunity to talk about this today, and I hope that it reaches individuals across the spectrum of our research field and our healthcare delivery so that we can work together to reduce these disparities in severe COVID-19.
Thank you again for those outstanding presentations. It's clear we all agree that the AHA can play a major leadership role moving forward in reducing the burden of adverse COVID outcomes, especially in relation to cardiovascular health, and also in improving the health of vulnerable populations.